So good afternoon. I'm Mandy Rodrigues, clinical psychologist in South Africa, in Gauteng. And I'm starting the slideshow with a video of a roller coaster. Just a bit of personal background. About 7 years ago, I was diagnosed with breast cancer, and I'm terrified of roller coasters. I'm really scared. When I was younger, it was not so much a problem. And a few days later, I decided I am going with my kids and I'm going to take all the rides with them because I had nothing to lose. And when I look at the fertility journey as such, I mean, the roller coaster ride, you got this fear and this trepidation, and it's up and down. You're screaming, you got people's hands to hold, and you can get off that ride at the end. You might start feeling a little bit ill. You might kind of close your eyes, but at least you've got that ability to control what you're going through. And we often talk about the fertility journey. This was my work in infertility started about 26 years ago when I struggled to have kids myself. And I remember thinking about this roller coaster metaphor and really struggling. Can you imagine going on this roller coaster ride and you have absolutely no control and you can't get off? And you can't just close your eyes because you're on the ride and there's nobody with you, no one screaming, no one holding your hand. You're on this alone. You're fortunate enough if your partner's with you and you've got his hand to hold, but maybe he gets off that ride before you do. And you're terrified to get off the ride, even though there's all these different barriers that you come up with and it wears you down eventually. You're very scared to get off because what if it's not what you wanted? And what if the rest of the rides, if the participants are actually successful and they're happy and they get to master that ride? So I think a roller coaster ride definitely defines what we're talking about with infertility. So if I go to the next slide, if we look at, again, the metaphor of a roller coaster, each step of the journey is marked with a different aspect of this ride. And there's initially this decision to enter treatment or fertility treatment, which is different to once you're actually involved in the process. And I'm going to address in this talk the emotional and psychological well-being and how important it is, and then give a few self-help tips at the end, and then warning signs you need to take heed of. So I'd like you to just look at this. I'm sure you can all relate to this 1-minute clip. I just want to share with you that I find it very interesting that a lot of our support groups here in South Africa and a lot of our agencies and people who've gone into the field of fertility, it is our survival story. And I know you might feel, well, Mandy, you're on the other side now, but a lot of us have tried to make sense of our journeys by joining this infertility awareness and support. So why is this important to deal with? We need to understand that even beyond the initial diagnosis of fertility, that entire journey needs management. And not only once you're pregnant, even beyond that. And the entire multidisciplinary team at a clinic is important. Now, if we look at therapies like alternate therapies, even though science is moving very fast, there is a lack of research that is very conclusive in all these areas. Although when I attended ESHRI in 2019, before COVID, it was very interesting that the keynote address was on more in a diet and time to pregnancy, which I'll get to now. And it was amazing that it wasn't a medical talk. It was more about alternate therapies. And there was a lot on the patient session and communication during the journey that was important. Now, by the time you reach the decision to go to a fertility clinic, you've already gone through one of those roller coaster rides. You've gone through surprise, but during that stage, you still feel that you can control your fertility, and we try and believe that it's circumstantial. We then take action, and this makes us scrutinize our behavior, maybe stop smoking and lead a better lifestyle. We then start getting irritated, where well-intentioned advice is met with irritation, and fertility triggers that I talk about start emerging, like going to baby showers and seeing pregnant women. And then we get angry, and that's where guilt, shame, and blame might start emerging, which is important in terms of the fertility journey. And then acceptance that possibly we need help. So it's at this stage that us as therapists and nutritionalists and acupuncturists, counselors, we have an inroad, because this is where patients are ready at the beginning to say, please help me manage this journey, and are open to information. When I speak about that keynote address, it was so important that Claire Roberts, she assessed that pre and early pregnancy diet is associated with fertility and health in pregnancy. So she was saying, if we can manage our health and our eating behavior, our nutrient intake, it would facilitate that we have a healthy environment in which to implant that embryo or in which to fall pregnant. But not only that, I found it very important that she said the more fast foods people ate, which is the more unhealthy their lifestyle, the more it had a transgenerational effect on people. So it didn't only have an impact on you being able to conceive, but on your children and gestational diabetes, perhaps, and on their children in the long run. And that's where the study came in. Does an apple a day keep the doctor away? Where they looked at underweight and obese people and saw that they were more at risk for a preterm delivery and low birth weight babies. And then also we know people who don't control their insulin during the journey or their diet, and people who are insulin resistant possibly have the complication of pregnancy-related diabetes. Now, when we look at this original grief cycle of Kubler-Ross, she explained that whenever there's a loss, and remember, even a negative result is viewed as a loss, we go through this wonderful, neat cycle, as she conceptualized, of the shock and disbelief, and I can't believe it didn't work, and bargaining. What did I do wrong? And why am I being punished? And then we get angry, which is often displaced. We blame ourselves, or it becomes this realistic anger, this anger where we're angry at the world, we're angry at the outcome, but we're not sure who to blame. And that's where we start using this blame and shame And then we go through depression and acceptance. But just like that roller coaster, unfortunately, the next cycle and the next cycle just wears us thinner and thinner. And if you look at the diagram on the right, I think it's more indicative of the fact that this loss or this grief we go through does not happen in all these neat squares. It actually happens up and down. We're fearful, and then we're in denial, and then we're numbed, and it's very hard to get off that. I want to look at guilt and blame in infertility. And I want to start off by looking at the relationship between couples and how it changes across the journey of infertility. And again, this could be from the start of you trying all the way to going through invasive treatment. There were a lot of studies on independent coping that said men tend to cope very differently to women to the fertility journey. Originally, in that first year, people do cope as a team. Everyone's gathering information, everyone's on board, everyone is kind of using what they can to optimize their ability to fall pregnant. Between year 2 and 3, the study saw that there was some disillusionment, but the couples were still coping. And beyond that, or sometimes earlier in certain couples, there's a phenomenon called independent coping. So this is where the husband and the wife cope independently. They found that the male is able to kind of box his infertility and still continue with kind of hobbies and work and family and marriage. But for women, it was all intertwined. And there was this elephant in the room often between couples. And this is when it created potentially a risk in the marriage. So just for all of you couples out there, it is not so much the infertility and the journey that causes a relationship problem, but the way in which you manage it. Now, if we look at guilt and shame, women are often reporting a sense of shame, which is more internalized. It's more blaming themselves and self-doubt, low self-esteem. And this makes them unable to share their journeys. Same as men, especially if there is a male factor contributor. Guilt is when we feel bad and we blame ourselves or maybe others. And this is what often emerges in conflict. If we look further at the studies on men and women, intimacy issues were a problem, and counselors need to be trained in relationship and sexual concerns. And it was so important that we did include the men in our discussions so that they're not isolated and the women are not going through this alone. And there are studies that show if men are more interactive in their wife's treatment, even if it means attending a scan or eating more healthily or kind of listening to their wives, there was a better time to pregnancy and higher fertility rates. Now, often I've found that the women are more willing to come and see me than the men are. And sometimes it's important that we need to say to the men that it's important you listen to this talk for me, not for you, but for me, is not to kind of bring in this blame or this shame or potential conflict. Now, if we look at guilt under very normal circumstances, it actually fosters a very normal society, but infertility is not normal. So if we look at the concept of guilt, it's a common experience, and 13% of people feel guilty during the day. It's more likely to happen with those closest to us, like 93% of people. And during this journey, it tends to be our partners, if we have a partner. The pros of guilt are that it helps us recognize when we could have made a better choice. So if you behave wrongly and you feel guilty and you betray your values, it's useful to be able to feel guilty so that we can follow norms of society or maybe correct our behavior. But the negatives of guilt is when we use it for something that is unjustified or baseless. So have a look at infertility. Before we look at that, I just want you to have a look at this slide and the next one. That feeling guilty about your journey or having shame has physical effects eventually along the way. And it can cause depression. And like I said before, it can become debilitating and toxic. And it robs us of our enthusiasm and our joy for the rest of what's happening and for our futures. There's also a damage to the immune system. And this has been proven in studies on psychoneuroimmunology. So not only does it have an impact on us emotionally, but guilt and shame tend to have an impact on us ultimately conceiving. Now, if we have a look about why is there so much guilt about infertility, there's almost a seductive side of self-shame and guilt. So we kind of feel if we can blame ourselves for something we did wrong, we can then potentially fix it and have a solution. But this is not what happens in infertility, unless we have a direct problem like needing to use a supplement or needing to use insulin or having an underactive thyroid. But as for the rest, there's very little that we can do. Because if you ask yourself these couple of questions in the dark pink, was your infertility deliberate or bad? So was it a bad behavior? Did you make a mistake? Because if you made a mistake, you can learn from those mistakes. And is infertility an inappropriate behavior on your part? It's definitely not. So in terms of infertility, feeling guilty and feeling shame and responsible if we did not cause a problem is actually baseless, and it doesn't help us in the long run. Now, this is always very interesting, and I'm going to play you a video. I'm sure many of you have seen it. It is when we're sitting with patients and we ask them whether they're stressed or not. There's a huge movement towards the relationship between stress and infertility, which I'll explain to you after this video. But this is often what we're faced with when we ask if patients are stressed. Let me go back to that slide.
Okay, Diego, nice to see you again.
Hello, doctor.
You here for your annual checkup?
Yes.
Good, good. Before we get started, how's everything been?
I'm still married, so pretty shitty.
Oh, you know what they say. Secret to a happy marriage remains a secret.
Oh, that doesn't help me at all.
Do you smoke?
No,
You sure?
no.
You're not sure.
I occasionally have like a cigarette or like a joint or crack.
It's a yes or no question, Diego.
Okay, yes.
Do you drink?
No.
Are you sure?
Like casually, like at a party or a wedding or something like that. Or like my house, alone, every night.
What do you drink?
Just like a glass of wine at dinner.
Okay, that's healthy.
And then a shot of tequila.
Okay.
And then another shot. And then a few more. And then some more. And then I usually pass out. Then I wake up and I take a few more.
So the answer is yes.
Yeah, I drink.
Do you take any drugs?
No.
Are you sure?
Occasionally I'll smoke a little weed here and there. Like I'll do a little blow at a party, some shrooms, nothing crazy.
Yes or no?
Yes, I take drugs.
Any prescription pills or over-the-counter medicine?
No.
You sure?
I take like Advil, Motrin, Tylenol, stuff like that.
How often?
Every time my wife talks to me.
Why?
Because I know it's going to give me a headache.
So the answer is yes.
Yes.
Diego, are you a stressed person?
Me? No, not at all.
How's your wife?
Okay, I'm stressed.
You engaging in sexual activity?
No.
Are you sure?
Like occasionally, like on our anniversary, stuff like that.
And this activity is with your wife? Well, whoever you're having sex with, are you using protection?
I don't like guns.
I mean, a condom.
Oh, yes.
Are you sure?
I mean, there are exceptions.
How many exceptions?
I can't remember.
Why can't you remember?
Because I drink.
Why do you drink?
Because I'm stressed.
And what do you do when you're stressed?
Prescription drugs.
And what causes the stress?
My life.
Well, Diego, if it isn't obvious already, I'd say the source of the problem is pretty apparent.
Yeah, I know. I agree.
Obviously, the biggest problem in your life is
I don't drink enough.
What?
What?
All right. So again, the relationship between stress and infertility is what comes first. Is it the infertility or is it the stress? And if we look at anyone going through IVF or going through any sort of fertility treatment, ICSI, IUI, we know that it's stressful. So that acute stress of having an aspiration or an egg retrieval and waiting for the result, everyone is stressed by that. But studies have shown that that acute stress, even though it moderately goes up, it does come down, and it's not related to the number of eggs at aspiration, the maturity of the eggs, viability, or pregnancy outcome. So acute stress tended to have no impact on control and randomized groups. Now, what are we missing? If we have a look at some of the more recent studies, they're saying that the patients we were seeing were more likely to experience perceived stress at work and a chronic type of work stress. Not only related to work, because many of you maybe have decided not to work and have decided to give yourself your best shot at falling pregnant. But we do know that the longer or the more chronic your stress is, the less likely you are to fall pregnant. So if we have a look at the slide before, we've recognized a specific personality type called the time urgent perfectionist. And research we did about 24 years ago showed that the more time urgent, so stressed about time, and the more perfectionistic a person was. And I'm not talking about attention to detail, neatness, organization. It was often good for people. But I'm talking about the way they were thinking. So all or nothing, didn't like being out of control, black or white thinking, didn't like critique. The more stressed they were on that measure of stress, the less likely they were to conceive, and the more likely to present with burnout. Now, imagine if I told you we could manage 90% of that self-induced stress, teach you when to stress and how to manage it better if the stress is real. Now, we divide stress into good stress and then bad stress. So good stress is something that we define as real. So that would be something like a flood, COVID-19, and drought, poverty. If we look at over the years and the millennials, people in dire circumstances have had very large families, and they don't seem to present with lifestyle-related diseases because they're acutely stressed, and that secretes a prompt adrenaline response and gets them to act on their stress. And it doesn't seem to be associated with autoimmune illnesses or time to pregnancy or infertility, cancers even. But again, it's only 10% of our day. If you had to make a list of the different triggers that cause a negative reaction in yourself every day, only 10% would be things that even a relaxed person would stress about. 90% would be self-induced. So 90% of the things we worry about are to do with time urgency and or perfectionism. So if you're stuck in a traffic jam, it's not real. I can promise you that the relaxed or well-managed people who are not chronically stressed just accept that that's how it is. They pick up the phone and say, I'm running late. But if you're a time urgent person, you're first of all irritated about the delay in getting to wherever you're going. And secondly, your perfectionism is stressing about the stupid drivers on the road. Now, what happens is we can't secrete adrenaline indefinitely. So our body has a mechanism of converting that to noradrenaline and cortisol. And that has the indirect relationship on the immune system. We ultimately want to reduce the amount of time that you do stay stressed. And even if, for example, on our original study group, we had between 63 to 87% of people falling pregnant on their next IVF, even if you weren't in that group fortunate enough to fall pregnant, you still were empowered to manage the stress of fertility better. Now, the link to managing your stress is below, and I'm more than happy to send more detail through to you. Tips to manage your journey. First of all, it's important to educate yourself, because the more predictable we find something, the more empowered we feel to act on it. So if we prepare kind of, what am I in for when I go for my first visit to a fertility specialist, it's more predictable and we're able to prepare for it better. The potential of sharing with others, it needn't be direct or in a support group. And in fact, we're looking now at how many people, especially due to COVID, and especially due to financial burden of seeing a therapist, are actually using support groups, or they're using online support, which is readily available from many platforms. There's a game, a shame and guilt game, that I will bring up with you now, that you can generate for yourself within a given day. And if your marriage is taking strain, I think it's very important that you seek kind of advice, not pointing fingers that there's a problem in the marriage, but just saying we can manage this together. And it's not the marriage, but the independent coping. Like I said, to manage your chronic stress. And we have an online self-help kind of 10-session course that does teach you to manage your stress. And then to manage diet, very important. And oftentimes stress makes us not eat properly, and it has this whole knock-on effect. And here in South Africa, we definitely value the need of nutrients and supplements to help individuals, whether this be DHEA, whether it be something else. It is something that we do look into and have various supplements that we use with patients. So making the process more predictable is discussing the detail, possibly with a nurse, maybe before you go in, and plan around your treatment. But don't let it dominate your day. So don't let it be an all or nothing where everything has to fall into place around your fertility cycle. Ensure you choose times when you can come to the clinic without undue pressure or time to travel. Make clear what to expect from your spouse or family. So here it's either disclosing to your spouse or family, or it's possibly deciding that you're not going to. And if you disclose, it could be forming a group where you're the admin, for example, and you're sending updates so that you're not having to reply to a lot of different messages. Again, just educating yourself is learning about your diagnosis and then throwing yourself back into your daily life. I will show you some skills on how to do that, because oftentimes we put our lives on hold, and when fertility doesn't happen or pregnancy doesn't happen, there's nothing else to fall back on. I just found this so useful that there are so many people on that roller coaster and they're all feeling alone. And specifically also 1 in 4 women who've had miscarriages, whether they be early or not, they tend not to speak about it and feel embarrassed. But actually, when you do open up and start sharing, you come more into contact with that 1 in 6 battling with infertility. Just touching on the role of digital media and cycle apps. Even though there might be limits in terms of accuracy and who is monitoring the social media sites, it does seem to empower the sharing of mood. And of course, on the back end for the sharing of data. It can be quite supportive through this journey. And studies have shown that even a video intervention increased fertility awareness a month later, and these effects were maintained a year later. And I'm busy doing a kind of guideline now for the European Fertility Society, and a big inclusion that is new to guidelines is the use of online support like stress management courses and support groups, but how to use them coming from reliable sources. So look at Shaymin Game. I like this game. It related to shame and blame, let me say. You can set up 2 glasses on your desk and get a stash of buttons or jelly beans, coins, and every time you catch yourself in a blame or guilt situation, you throw a jelly bean into the one glass. And every time you tell yourself it is what it is, you throw it into the other. At the end of that first week, you tally them up, write them down, and you start again. At the end of the second week, the baseless use or the baseless guilt glass usually has far less beans. So that's the time where you're saying it is what it is and I have no control. And try and aim, because it's a very visual task, try and aim this to a more positive behavioral change. The other thing is managing your stress, and we've spoken about this in great detail. I've also found that I wrote a chapter for a textbook saying, why do people who adopt possibly fall pregnant, or people who, I don't know, give up the fertility journey, then fall pregnant? And it's not about relax and it's going to happen. And when we looked at this in detail, it's more about they had some sort of peace of mind. So they had merged their fertility plans with their other plans in life. And they had looked at kind of the worst case scenario, which for them was maybe giving up or possibly going the egg donor route, and having that peace of mind and dealing with that next step would often alleviate the stress of the step before and create that peace of mind, and pregnancy rate would go up. If you're married, I suggest that even if husbands don't attend ultrasounds or visits, is at least to ask their wives, and wives to understand that men are solution driven. So they're going to give the answer of, don't worry, this is going to happen, or let's take this action. They often don't want to see that you're struggling because they don't know what to do. So often what I do with couples is I have a pack of cards with different fertility triggers or hooks or situations on them. And I give one deck to the husband and one deck to the wife. And I get them to almost play a game of snap, almost put what's similar together so they know what each is going through, and then what is very different for the other spouse. And then that creates an understanding and a discussion that's more proactive than just not addressing that elephant in the room. Now, I like these two cartoon strips that therapy might not be for everyone, and especially not for one partner, possibly. And even if not, then you go for yourself. Now, it's important to be realistic about the outcome and your plan going forward. So if you can break your fertility process into manageable parts, whether it be kind of long-term or whether it be just month to month, kind of your stimulation and your first ultrasound, and get through your second ultrasound and get through aspiration. And then if the cycle doesn't work, plan for a follow-up appointment as a form of closure. And like I said on the previous slides, is have your next step in mind to create this peace of mind. This is just a goal list that helps people to kind of put their lives, or to take their lives off hold, where I get couples to write down what are your 5, 1, and 3 month goals in terms of all those different topics. And then to see that they're not all fertility related. There needs to be some that are encompassed kind of below that, so that life is happening while you're trying to conceive. And finally, my conclusions. Recent studies have shown that 40% of people who present for their first visit at a fertility clinic already have a psychiatric diagnosis. And again, they're talking here about anxiety and depression. And the theory is it's not that it's anxious and depressed people who present with fertility problems. It is that the journey that has led up to them having to take that next step is already creating an anxiety and a depression. Anyone with a pre-existing depression can worsen as they enter this journey. So if there's a history of bipolar, a history of a major depression, it can worsen as you go through. Another risk factor, again, we've spoken often about the strain on the marriage, but then is presenting with a post-traumatic stress disorder. So even though we know that depression is and anxiety is a reaction to infertility, so is post-traumatic stress. If you're exposed to a robbery, you probably get fearful every time it gets dark, every time you're alone. If you are on the road, or if you go somewhere dangerous. So it starts generalizing. And the same with infertility. It becomes something that generalizes. So instead of just being specific on that roller coaster to the end of the ride that didn't work and you're starting again, it is now about every dip, everything, every pregnant woman you see, every message you get that someone's pregnant, every time you drive past your fertility clinic, those triggers just seem to come all the time. And your life seems to be completely revolving cycle to cycle. And then a last factor is when your insulin is high, you need to manage you don't necessarily have to be on a completely restrictive diet, but just seek alternative therapies, especially if it's a type 2 diabetes or it's not a primary diabetes, it's lifestyle induced. And I think then you need to get support and use medication and use supplements. And yes, I hope this has helped. And any information that you need, if you can just contact the point of reference that will be at the end of the slide. And again, the slides will be available, I think, on Nutrapharmaceuticals website, so that you can download the talk for future reference. Thank you very much.